Yay Networks.
Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rahban. And on today's episode, we're going to be talking about actually answering your Q&As. As you know, every so often we ask you, what is it that you want to know? And then we try to give you some insight as to the specific questions you guys have been asking. I'm joined by my producer, Maria. Welcome.
Hi there. By the way, I want you to know these are some of my favorite episodes because I get to learn a lot from these questions and things that I'm probably curious about, and I'm sure other people are curious about as well. So
right, yeah. Well, you know how it is. You know how those games where you get to ask questions, you write them on note cards, and you're always hoping somebody else is going to ask the question you're embarrassed to ask. You're like,
exactly.
I don't want to ask that, but oh yeah, that's great to know. So hopefully some of the questions you guys may have at home are going to be answered here today. As always, we do a sort of a prompting and asking questions. So if not this week, then perhaps another week. So fire away, Maria. What do you got?
Okay, so we have our first question from Christina Lopez Hertz.
Christina Lopez Hertz. We try to throw a shout out to you so you know who you are and if your question's being answered.
Yeah, dark circles and hollowness. How to know if surgery or fillers?
So that's a fantastic question. Dark circles and hollowness around the eyes. When to know if you're a surgical candidate or non-surgical candidate. Is that right? Or fillers, is that what I wrote?
Yes.
Okay, so this is the under eyes are really, really difficult areas to fix. As such, create a lot of problems. Areas that are hard to operate on or treat then create a lot of bad outcomes because obviously if it was easy, then surgeons and doctors would do it well. So the under eyes have three parts and three problems. Each part and problem has its own treatment. So issue number one is the bag, the actual puffy part that sticks out and protrudes from your eye. So some people have it, some people don't. It's usually age-related, but it's genetic, and it gets worse with time. The puffiness or the bags are generally treated with surgery in terms of taking that bag, historically removing it, which used to cause extra hollowness because now you remove the fat. And now we do a more advanced treatment where we reposition it. We take the fat and we push it in other places so it looks good. If your fat protruding or herniating is a small amount, then you can get away with camouflaging it with using filler around it and bringing the area around it up to the level of the fat. You hear me? So if you have mild fat herniating or mild fat bags, you can treat it non-surgically. Otherwise, you can try to treat it surgically with a lower eyelid, what we call transconch blepharoplasty. The second issue is the actual hollowness or the trough, we call it a tear trough, that is around your orbit and you can see it. And usually they actually go in hand. As the hollowness or that sort of trough is exposed, usually your bags become exposed. The treatment for any hollowness is filling it. Hollowness in your cheeks, you fill it. Hollowness in your temple, you fill it. So hollowness around the eye, you fill. Now, the issue is filling around the eye is 1,000 times more difficult than filling in the cheek because you are now filling under paper. The eyelid skin is so thin, that area, that anything you do, and if you do a shitty job, it's going to be visible. Lumpy, bumpy, overswollen, et cetera, et cetera. So I use a very specific technique. I use cannulas. I use very specific products. Actually, I only use Restylane. Anything that goes under the eye that doesn't belong there is going to be a disaster. So the second thing is the hollow. The third thing is the skin quality. Crepey, wrinkly skin versus thick, solid skin. For skin, if you have a lot of it, you can do an eyelid surgery and remove some of it, or you can use some types of lasers to resurface the skin and tighten it. Those are your two options. Either remove the excess skin and or use some laser to make it tighter. The last and final issue is discoloration. Actual pigment. And there are people, and they're very unhappy and unfortunate, that are born with darkness in that area. It is not due to the hollow and it's not due to the bag. It's due to the color of their skin. And the only treatment is makeup. No laser, no tattoo, no nothing. And unfortunately, I do have friends of mine that have this problem, and they have called me on many occasions, and they mistake hollow darkness with pigmentary darkness. And when you have pigmentary darkness and you go put filler in, it doesn't change the color of your skin. So that is the answer, long and short, for under the eyes.
And
Next
it
question.
only gets worse, right? With time?
Yeah, I mean, everything gets
Hollowness?
worse with time. Everything. I mean, my eyes have never been as hollow as they are now, and they look like crap. I mean, that's why I have big glasses on. I mean, everyone's hollowness, everyone's sagginess, everyone's loose skin just gets worse, and under eyes definitely age terribly.
Yeah, because I have a friend who, in her 20s, she had the bags under her eyes, and it was always covering up with makeup. And as she's older now, she's in her early 50s, it just looks worse. She has to put more makeup on. So,
Yep,
yeah.
I agree. All
Okay.
right, what do you got?
So the next one is Bartholomew, nostrils that are not symmetrical and how to correct it.
All right, Bartholomew, great question. We just did a huge segment on noses, and you'll hear that in there. So asymmetric nostrils, let's begin. Number one, understand that that is every single human being that walks the planet, their nostrils are asymmetric. Just do yourself a kind of a fun game. Have everyone you know lift their heads up, walk underneath them, take photos of their nose from underneath, and you'll notice that everyone's nostrils are asymmetric, everyone. The question, as always, is how asymmetric and what kind of asymmetry. So by that, I mean, is it mild, in which case 100% don't mess with it. Don't mess with it. You'll go to try to fix it and it'll become worse. The second, in addition to how is, to what degree is what kind of asymmetry? Is one nostril higher than the other one? Is one nostril more in than the other one? Is one nostril more curved than the other one? Many times you don't know, but your surgeon will. So what can you do with nostrils? There's really only one thing you can do. Let me rephrase that. There are two things that affect the nostril. One is the rim. That's actually the part that connects the tip to the base of your nose. That's the part that curves over. So sometimes that rim is a little higher or retracted on one side more than the other. So you can see the nostril more on one side, the other. That can be corrected by doing some surgery. And the other is that there's more flare to one side and the other. And we do what's called an alar base reduction, which is super tricky and very complicated. And that's where you clip the outside of the nostrils and narrow them or suture them. That's how Michael Jackson partially became the way he looks, is he had that procedure done like 4 or 5 times. So in general, my caution to you is nostril asymmetry is a very dangerous thing to chase. And unless your nostrils are severely asymmetric, leave it be.
So the next question is from Jeannie. I won't say the last one. Jeannie Bitches. How soon?
Jeannie Bitches. Nice, nice handle.
How soon after I stop breastfeeding can I go in for a consultation?
So how soon after breastfeeding can I go in for a consultation? I'm going to tell you the following things. So there are 2 parts, of course, is the consultation, and the second is surgery. So you can go in for a consultation immediately after you're breastfeeding. You can go into a consultation while you're breastfeeding. Nothing's going to happen to you. The question is, when can I have breast surgery? And the answer is you want to wait 3 months till the last time you saw a drop of milk. Listen to me. I didn't say 3 months since the last time you breastfed. Some women stop breastfeeding, and very soon thereafter, their breasts dry up. Some women stop breastfeeding, and 6 months later, they still have milk coming out of their breasts. So if you have milk coming out of your breast and you go do any type of breast surgery, especially an implant-related breast surgery, you are at a higher risk of complications because your breasts are engorged, they have milk, the ducts are not sterile, they have bacteria in them, et cetera, et cetera. So you want to wait 3 months till the last time you see a drop of milk. You also don't want to stimulate your breasts, because when you are breastfeeding and you stimulate your breasts, that's rubbing them, touching them, that increases the cycle and keep telling your body to keep making milk. So, some women, there's a lot of stuff online. They drink sage tea, they wrap their breasts with ace wraps, et cetera, et cetera. But you definitely want to make sure that you don't see any milk before surgery, not the consultation.
Okay, the next one is from Lush Bermuda.
Lush Bermuda.
Right. Mini liposuction for targeted areas, minor procedures for slim athletic people.
Okay, so I selected this even though I hate the word mini. Everyone that knows me, I go on like off the deep end off using the word mini, because mini is usually a tagline to make patients feel like what they're doing is minor. And I've never seen a surgery be minor. But in this instance, mini lipo is actually the funny thing. It's the appropriate type of lipo. Lipo should be mini. I was thinking of doing a podcast on all the things that I hate, and we might have to do that, Maria, like all the things that make me go nuts. And one of them is this 360 lipo, this thing where like I'm 5'3", I weigh 175, and I want to suck up all the fat out of my body and stick it in my butt. So I'm not a fan of that concept. But back to your question, I'm athletic. So liposuction was designed to be targeted, which means that I'm in shape or moderately in shape, not overweight. And I like the overall shape of my body, but there's a little bit of outpouching in my love handles. There's a little bit of fullness in my saddlebags. I have just a little bit of extra in my inner thighs. Right at the lower part of my abdomen, there's a tiny amount of fat. That is how liposuction should be used. When liposuction is done more aggressively, meaning I remove a lot of fat, trying to just make your regular shape a smaller version of itself, you will be left with irregularities, dense divots, and loose skin. You hear me? I don't care if you're 20, 30, or 40. I can name probably 50 tummy tucks in 30-year-old women who have never had a child because they had liposuction in their 20s. Because the skin eventually catches up to you and gets loose. So to answer your question, if you're fit and you have a little bit of fullness in a little area, that's the ideal candidate for a tiny, very selective area of liposuction, or as you phrased it, mini.
Right. The next one is from eBranco75.
eBranco75.
What would be the best solution for sagging jowls and jawline? Oh, I'm suffering a little bit of that.
The question was, what is the best treatment for sagging? What was it?
Sagging jowls and jawline.
Sagging jowls and jawline. Okay, so there are certain areas that are tricky, and the lower eyelid was one of them, and the jaw and the jowls is another. Right. So every human being, even Angelina Jolie and Brad Pitt, every human being eventually generates jowls and sagging neck skin and an obliteration or softening of their jawline. That's a fact. So it happens gradually and in stages. It usually creeps up at 50 and in your early 50s. And you start to notice that your jawline is not as crisp. You have the tiniest amount of looseness in your neck. And you have a beginning of what's called a marionette, which is the line that connects the corner of your mouth to your chin. Then, as you can imagine, as the years go by, that trio, the marionette, the jowl, and the neck excess increases. Now, if you are heavyset and lose a lot of weight, if you have poor genetics, if you've been in the sun, there's a million factors that can accelerate or slow it down. But every human being will eventually develop these three items. In its earlier stages, it's just starting. Then what you do is you try to camouflage it. The bands in the neck, you can Botox. The jowl can be camouflaged like the puffiness of your lower eyelid by filling in front of it so the jowl doesn't look like it's sticking out. The marionette can be filled in. I do not believe in any machines, devices, or cockamamie crap that's designed to lift your face and tighten your skin. Listen again, lift your face and tighten the skin. There are none, zero devices that are really been proven to work. And all you do is A, waste money, and B, make matters worse. The only thing that will fix your neck, jowl, and marionette is a face and or neck lift. Period. But when you're 55, you may not be interested, but at 65, it depends on who you are. We do facelifts in 48-year-olds, and we do facelifts in 78-year-olds. When you get a facelift at 48, it's early. You start in a jowl. You don't like it. You're one of those people that gets gas often. And the surgery is, I hate the word mini, but smaller. You come in at 78 and you wait till your tank is empty and your facelift is larger. It is the same crap, but in mild, medium, and severe versions. Nothing else works. A neck lift, listen carefully, is a facelift. We just call it a neck lift because people don't like to hear the word facelift because it makes them freak out. So, oh, I got a neck lift, I didn't get a facelift. It's all the same crap. So to answer your question, if it's early on, those are the things that I would do. I have an all-therapy machine, by the way, which was touted as the only FDA-approved face tightening device. And I would tell you that I've been very underwhelmed. It was $100,000 and some odd device, and it's average at best, but it works really well in fat faces with a lot of fullness. It doesn't work as well in skinny faces. I think it melts fat, to be honest with you. So anyways, that's my answer to your question.
Well, we're going to go to a break, and we're going to ask answer some more questions from our followers. But we'll be back with more from Plastic Surgery Uncensored.
All right, welcome back to the second half of Plastic Surgery Uncensored. We are doing a Q&A with producer Maria. And what you got for me, Maria? What's the next question?
Well, another one that's coming up is from Jasmine Whiteley. Mental health.
Jasmine Whiteley. I love to repeat them like I'm at a bingo game.
Yeah.
A25. No,
right.
I'm just kidding.
Mental health and cosmetic surgery. This is a good one because I think there are a lot of people that first need to see a psychiatrist or a psychologist before getting plastic surgery.
Well, if the case is, that means everybody, because I think we all need to see a psychologist or a therapist, period. You would not see a dentist. But that's an amazingly good question. So it has two ends of the spectrum. There is the stereotype, which is, if a person is getting cosmetic surgery, then they're insecure and they have something wrong going deep inside. They don't love themselves and they need to seek happiness before they go fixing their face. That's a stereotype, and that's bullshit.
Yeah.
Conversely, the idea is that, plastic surgery will make you happy because you'll look amazing and therefore you feel happy. Also bullshit. So that's both ends of the spectrum. There are instances where each of those is true and instances where each of those is not true. Unfortunately, the overwhelming majority of surgeons do not give a crap. They're in there, you come in and you say, hey, I'm a nail. Can you fix me? And the guy says, sure, I'm a hammer. I can fix you. And that's the end of it. I have a big nose. I have deflated breasts. I have excess skin in my belly. Can it be fixed? Yes. But I spend an enormous amount of time talking to you. And when you talk to patients and ask them questions, the truth comes out. So there is overt mental issues, and then there is the subtle mental issues. The overt mental issues is, hey, I have bipolar. Hey, I am a manic depressant. Hey, I have schizoaffective disorder. Hey, I have been admitted in the hospital for mania. I have a therapist, a psychologist. I'm on a bunch of medications, and all that is fine. As a matter of fact, I am always grateful when a patient is transparent and honest when they come to the consult, because they can just withhold information and I wouldn't know any better. When I know they have mental illness and they are being treated, I always ask for a psych clearance. Not in a bad way. As a matter of fact, they're the better candidates because they're actually being seen by a mental health professional and they're under care. And what is it that I'm checking? Why do I need a clearance? I'm getting a clearance because I want to make sure that as a result of the stresses of plastic surgery, the recovery, that whatever mental illness that they are suffering from does not get exacerbated and that we're ready as a team. That's why I do it. Not because plastic surgery is terrible or good or bad, or they have, everyone's like, oh, you must see so much body dysmorphic syndrome, disorder. I have seen it like twice in 15 years, and I spent an hour with everyone. It is so rare. It is more rare for people to be depressed or anxious or, all those things. So number one, if you have some psychiatric condition, awesome for sharing it. I'm so happy you're being cared for. And we want to make sure that your therapist and you and me are all on the same page.
And could also the medication that they're taking could affect?
Not really affect the surgery. It just means that they're on medication and that medication takes care of them and keeps them mentally stable. And now we're going to do an event, like a major life-altering event. And I got to make sure that they don't need to be on more meds or aware or see their therapist more often or whatever. The other event, I've had patients who have been suicidal. So what do you think? I pay a lot of attention. I said, okay, well, tell me about, when I was younger, I had this terrible time in my life. I'm not going to penalize them for being honest. And I'm going to make sure, that nothing pushes them over. And I always get a psychiatric evaluation by their therapist. Those are easy ones. The more difficult ones are the ones that are elusive or hidden and they don't tell you. And those require time. If you don't ask the patient any question other than what's wrong with your breast, how big do you want to be? Great, no problem. Show me a picture. Great, done by. You'll never know this. But if you speak to them and kind of dig and dig and dig, they start to kind of show you little signs. And I remember vividly a young girl that I was speaking to. She was very, very shy, no eye contact, a little bit more meek than I would have expected. And I just kind of kept probing. So why are you doing this? Why? And then she started just bawling profusely. And it was one of those situations where she had broken up with her longtime boyfriend. She was in distraught. She had lost some weight. I could tell she was very thin. And she was kind of doing what we call, therapeutic plastic surgery, revenge plastic surgery. All those things are terrible. And we spent a good 30 minutes, not on her breast, but on her state of mind. I said, listen, terrible time. You're going to make a horrible decision. Go gain some weight, get yourself stable. This too shall pass, and come back. And I swear to God, she came back. She was the best patient ever. She had gained 10 pounds. She was so happy. She wrote me the most gorgeous, lovely card. And that worked out great. So your answer to your question is yes, of course, mental health really matters. It's really incumbent on the physician to be able to dig for the more non-obvious mental health issues. But those kind of like body dysmorphic, those things are actually quite rare. And really, it's pretty obvious when they come in.
Okay, our next question is from One Trip Beyond.
One Trip Beyond.
Right. It says, how you evaluate someone for rhinoplasty and say yes or no?
So I did a massive segment on rhinoplasty. I've done actually a bunch. I actually accepted this question because I think the question is very good. How do you evaluate someone and decide yes or no for nose job? And I think that's actually a really good question because number one is you must examine them physically. I do a ton of Skype and FaceTime internationally, et cetera, and it's great. But every single patient I operate on, I see the day before. Why the day before? Because I've canceled surgeries because they come in and I examine them. I'm like, oh shit. I look inside their nose and they have a perforation, or I feel their skin and whatever. So 100% the key to evaluation by your surgeon is photos help, all that is good, but nothing takes the place of a physical exam. What determines whether or not I'll do it or not is whether or not I feel they will be better, not different. So what does that mean? I feel wholeheartedly as a result of doing the surgery, their appearance, their nose will look better than it currently does. And there are instances where they have very difficult anatomy. They've had multiple surgeries. They have super thick skin, or they look really good. And I feel that their surgery will not give them any real massive improvement, except just make them look different. Different to me is moving side to side. Better means moving forward. And if I feel that it's after all this heroic effort, you're going to look just slightly different, another variation, but not much better, I won't operate on you. Because in order for you to be a good candidate, you need to be happy when I'm done. And if you're have no real gain to be had, then it's pretty much certain you're going to be unhappy. So I don't want to be involved in all that. And that's how I decide.
Okay, next question is from Tammy Q12. Mesh,
Tammy Q12.
Right, mesh or no mesh in diastasis recti?
Okay, so we have 5 episodes on DR, diastasis recti, the separation of your muscles that occur from pregnancy. So common now because of twins and IVF and multiple pregnancies. So I'm just going to say just a brief comment. When I fix DR, and I fix some massive DR, I mean, this is definitely an area of expertise of mine, I have never used mesh. Mesh being some foreign material to tighten, reinforce, fix the DR. DR is not a hernia. You can have a hernia in a DR, but a DR is muscle separation. A hernia is a hole in the abdomen. Totally different. And I do not feel, and I've done some severe cases, that there ever is an instance to need mesh in pure DR. So no, I hate DR. I mean, I hate mesh.
Yeah, I was going to say. Okay, the next one is from KDK1.
KDK1.
How and why would you do a brow lift?
How and why would you do a brow lift? So a brow lift addresses brow sag. Brow sag usually occurs in the tail or the last third, the outer third of your brow. What does that mean? As we age, everything sags, eyelids, neck, breasts, belly, everything, and your eyebrows are no different. Many times patients come in and seldom do they ask for a brow lift. 99% of people ask for eyelid surgery because what bothers them is that the space between their eyebrow and their eyelashes is getting smaller. When they go to put on makeup, they have extra skin. There's a fold in the corner of their eyelid. They complain of extra eyelid skin. By the time you go to your doctor and say, I hate the eyelid skin, you have brow sag. Brow sag contributes to the excess eyelid skin you have. So everyone who has a little bit of excess eyelid skin, almost everyone has brow sag too. They work in conjunction and in concert. So the brow elevation is almost always done in conjunction with removing a little bit of eyelid skin. The problem is that you think that all the extra on your eyelid is due to your eyelid, and it's not. There's also some brow sag. So usually the magic number is 40. 40 years old is when you're starting to generate that little bit of fold and a little bit of excess. So we usually do eyelids and brows between 40 and 50, and usually facelift from 50 on. So the way you do brows is generally most patients only need the tail or the last third of their eyebrow elevated. If you go in front of the mirror and put your hands on your forehead and pull your forehead up, your middle part of your brows between your nose will rise, and that makes you look like a weirdo. It makes you look surprised. Seldom does the middle of your eyebrows sag. It's almost always the last third, and we remove that skin from the corner in your hair tuft, just on the sideburn, the outer forehead region. And we do it with a very small incision. It's called a lateral limited brow lift. And then every once in a while, someone comes in with a boatload of sag. Their forehead is really heavy and the whole brow needs to be elevated. And we do a kind of one that's from side to side and elevate the whole brow. There is a third option, which is called endoscopic, where they do it with cameras and scopes and things like that. I'm not a huge fan, although it's not uncommon, but that also is a viable option. So first and most importantly is figuring out if you need it, then what kind you need, and then the execution.
Okie doke. And the next one.
A growling dog.
Yeah, he's on top of me there. The next one is from Tina City 1.
Tina City 1.
Breast reduction second time around.
So this is super, super important. Breast reduction or breast lift second time around. Why would you ever do that? Why? Because you did it when you were 20 and now you're 45. It's resagged. You did it when you were 20 and now you're 40 and you've gained a lot of weight. You did it and you lost a lot of weight. So sometimes it's necessary to redo it. Unlike a breast augmentation, which you can do 2 or 3 times with less concern, when you do a breast reduction or a breast lift, you have to relocate the nipple. It's down low and you're bringing it up. When you do that, you have to cut some of the blood supply to that nipple. There are multiple different patterns to do that. The problem is without your surgeon who's doing the second reduction or lift, knowing the previous surgeon's pattern, you run the risk of killing the nipple. Nipple necrosis. It turns black. It dies.
Nasty.
Nasty's right. And so why I accepted this question, and I think it's super important, is if you had a breast reduction and then you go to do another one, you're only looking at what's on the outside, meaning the scars. And most of them are done through an anchor, means it looks like an anchor. That's irrelevant. What's relevant is the pattern of blood supply underneath that keeps the nipple alive. And you cannot know what that is without the old operative note. So when I do it, which I try to do seldom, it's risky, and we always are worried about the survival of the nipple. So just keep that in mind if you're redoing a breast lift or redoing a breast reduction.
Now, can I ask you something? If they did a breast lift and the incision is around the nipple, is it also, in other words, not the T, but there's some incisions that they cut around the nipple. Is that also as dangerous?
No, that's a good question. So lifts and reductions have 3 outer patterns. Outer meaning the scars, inner means something more complicated. The outer patterns are donuts, lollipops, and anchors. Cut around the areola, and down, around the areola, down the breast, and in the fold. This concern applies to the lollipop and the anchor, not so much the donut. The donut is pretty safe to redo as many times as you want.
Good.
Good question, Maria.
It applies to me.
I figured much. I figured it had something to do. I have a friend.
No, I'm pretty upfront. No, but I've hesitated to do it because, first of all, I don't have time to even think about it. But 2, because to me it's like scary.
No, and that's okay. It's not a problem.
Yeah. Okie doke. So I think we have all the questions for now. But
we're done?
Yes,
okay.
That's it. But I think it'd be great if we get more questions from your followers and fans. This is the best way to kind of get people going and preventive and try to get in check with if they do want to do surgery. And I think this is the best way to do it.
Well, great job, guys. Thanks for sending in your questions. Continue to pay attention, follow, download, subscribe, share this with your friends. In order for this podcast to be viable, it needs to get to enough ears. Otherwise, it's hard to maintain it. So, when I see a lot of people sharing this and we have more listeners, it makes this all well worth it. Anyway, another great episode. Thank you all. And we look forward to tuning in at the next episode. I'm sure whatever it is we're talking about will be interesting and entertaining.
Thank you for listening to Plastic Surgery Uncensored with Dr. Rahban Rahban. We would love your feedback. If you enjoyed this episode or if you find our podcast helpful, tell us why. Leave us a review and make sure you subscribe on your favorite podcast platform. If you have a topic you would like for us to discuss in an upcoming episode, please reach out to us on Instagram at Dr. Rahban Rahban, on Facebook at Rahban Rahban, or at RahbanRahban.com.